Hello, everyone, and welcome to this latest program on how NQF members are responding to the challenges around COVID-19, shovel-ready social care innovations to prepare for value-based payment and COVID-19 responses. We're glad you could join us, and we hope it'll be informative. My name is Jonathan Sullivan, and I'm the Vice President of Product and Membership Design at the National Quality Forum, and I'll be your moderator today. This program was made possible by you, the members of the National Quality Forum. Members are the driving force behind NQF's mission to advance measurable health improvements. Together, we do the work that enhances health care, makes patient care safer, and results in better outcomes. Members continually demonstrate their shared commitment to the NQF mission through engagement and service, and our presenters today, John Shaw and Matthew Roberts from the SCOH Data Integration Member Network, are no exception. John Shaw is the president of NextWave, a health policy research and evaluation firm focused on measuring quality and value and addressing health equity and social determinants. As a health systems management engineer, he supplements NextWave's policy and measure analysis with bottom-up viewpoints through the eyes of frontline workers, both in health and across sectors. He is a long-term contributor and member of the National Quality Forum and currently serves on NQF's Member Advisory Council. Dr. Matthew Roberts is an Assistant Vice President of State Healthcare Assessment at iPro, where he leads healthcare provider compliance monitoring activities. He was previously a Health Informatics Senior Director and directed Informatics and Health IT at the Chicago Department of Public Health. At the Illinois Department of Public Health, he held leadership positions in communicable diseases, long-term care, and emergency preparedness and response. Some quick logistics before we get started. We hope you'll take an active role in the question and answer portion of the program. However, please help us stay on topic and refrain from questions or comments that aren't related to the information being shared today. We have muted all phone lines to ensure that unexpected noise does not interfere with the program. We'll be taking questions both through the chat box on the web interface and through the phone. If you're on the web, we're displaying instructions there for how you can ask a question. If you're only on the phone and unable to see the instructions, I'll prompt the audience when it's time for phone questions. At that time, you can hit *7 on your phone to unmute your line. And when you've asked your question, please mute your line again by hitting *6. With that, I would like to turn it over to National Quality Forum CEO, Dr. Shantanu Agrawal, to kick off the program. Shantanu, you can hit *7 on your phone to unmute.
Great. Thanks, Jonathan. Can you hear me?
I can.
Excellent. Well, I want to thank all of you for attending this webinar today, shortly after the pandemic, and just really understanding how broadly all of us were going to be impacted by COVID-19. We launched this series of webinars that, again, as Jonathan had said, is member-driven, and it's really for our members to better understand the impact of the pandemic across all of the different sectors of healthcare and across all of the different work that we collectively as a community do. I hope if you've had a chance to attend one of these webinars before, that you have found them to be valuable. We're certainly open to your input on what other topics we bring to the fore so that you're getting access to the information that you want, and very importantly, access to the dialogue that you want through NQF. I really thank Jonathan and his team for putting on these webinars and pivoting so quickly to help make them happen. Let me also thank our two speakers today. John has been extremely involved with NQF and our work for quite a bit of time, and I really welcome as well Dr. Roberts and the expertise that he brings. I'm really excited about this. I think it's incredibly important to be talking about innovation in this period of the pandemic. Quite a number of our speakers have approached this topic through their own lens, and particularly the issue of addressing social determinants. So with that, again, I will thank the speakers and thank you all for attending and turn it back over.
Thanks for kicking it off, Shantanu. And now I'll turn it over to our presenters today, John Shaw and Matthew Roberts.
Okay, can you hear me, Jonathan?
I can.
And can you hear me? This is Matt.
I can.
Great.
And you can hear me too?
Yep, we got both of you. You're good to go.
Okay, great. Okay. All right, so background. Why are we here? Part of where this started is Matt and I were both on the National Quality Partners SDOH Data Integration Action Team, and this is a follow-up to some of the work that happened there. Even during that project, we found that things were changing every month or every week. And so because it was so rapidly changing, a number of us that were on the action team decided to continue the process through this mechanism and provide webinar follow-ups as we go forward into implementing more and more of the social determinants. And so there is a need for continuous updating, and we're going to be talking today about processes. And a lot of the thought we put into this, we had originally designed the webinar just as a preparation for value-based payment and addressing the movement towards upstream focus on the social determinants. And as COVID hit, we realized that many of the processes that were already being put in place were ones that were needed to address the COVID pandemic. And so we decided to update what we were going to present, add a little bit additional COVID focus, and show where the work that we've already been doing for the last several years prepares us to be able to rapidly address COVID-19 now that we need it. And the big thing we can do, we hope, is avoid that traditional 17-year healthcare improvement cycle. We need answers quickly. And the good news is we've got some. So what we're going to be talking about today is a little bit of frameworks and links to social determinant innovation compilations. So basically provide links to resources so that you can, following today, pull up the slides and just click on a number of resources that can help you find what it is that you're looking to do and find what the results are of those that have already tested it over the last couple of years. We're also going to provide some specific examples applicable to the current COVID-19 efforts, some of the new things that have arisen with the COVID crisis, as well as a detailed case study that Matt will go through where he was involved in some of this work and pinpointing how what they did already in Chicago when he was there also applies to today's efforts to look at COVID. And hopefully we'll also hear from you to get the insights from you. Next slide, Jonathan. All right, so the part of the context and clarifying terminology, this was a factor that came up in the discussions of the action team, is really differentiating what we're talking about here. So social determinants is the middle box, so it's the causes of poor health and focused on communities or regions, the underlying conditions. But above that is the individual person level, the effects of the causes. What does this particular person need to have addressed as part of their movement towards health? And then the bottom factor was the structural determinants. Some of the things like poverty that are the causes of inequities and disparities, and they're more broadly focused on cities, nations, and states and the whole world. And it was helpful to us to differentiate that. So Health-related social needs are a person. Social determinants are the local community, and structural determinants are the broader efforts that may take a lot more effort to address, and maybe COVID gives us an opportunity to start addressing some of them. Next slide. So you've probably all seen the concept of looking at health from a stream model. So the upstream pieces, community impact. In COVID terms, this is the risks of exposure. Things like social distancing come into here. Looking at safe transportation, does the individual have space in the community to be able to quarantine and isolate if need be? And those may have a lot to do with the structural determinants and social determinants that exist in the local community. And then the individual impact, looking at screening and referral of their individual needs, particularly the needs of those that are most at risk, the vulnerable populations. And what we're trying to do in all of that is look downstream and try to prevent and avoid deaths and overwhelming the healthcare delivery system. Next slide. So we're going to look at framework for integrating social care from National Academies of Medicine, and this was a recent framework that they put out last fall, as well as looking at the model for change, E.M. Rogers' Diffusion of Innovation, that's been around for decades, but can help us visualize how the change process works and where the control points may be. Then we're going to look at major efforts and learning resources, sort of the lists of what has been going on in various communities throughout the country over the last few years, as well as then the examples of Health Begins, All In, and Dash, and some of the real world experiences from that. Next slide. So this is the National Academy's model of the activities needed to facilitate integration. I'm going to go quickly through this. This is one of a series of frameworks that have come up over the years, particularly starting in about 10 years ago with the World Health Organization's framework for addressing social issues. And what I wanted to point out to here is the middle of this is awareness. So it's difficult to address an issue if you're not aware that it exists in the first place. So you can't fix what you don't know or can't see. And so that's the first step here. And one of the big silver linings, shall we say, of COVID is it's really shined the lighting on the equity issues and inequities of the populations that are most at risk in developing COVID. The top part of it is focused on individuals, adjustment and assistance, and the bottom is focused on communities, alignment and advocacy. Next slide. And this is just an example looking at transportation, and I don't have to go through the details. You can do that at your leisure and access the full report online. Just go to the National Academy site and type in integrating social care into the delivery of healthcare, and it'll pop up the full report. What I did want to do is look at on the right-hand column, the second box down, reducing the need for inpatient healthcare appointments using other options such as telehealth. And so we've been talking about telehealth for decades, and we now have an opportunity to really implement it, and we're probably going to see major movement in the direction as a result of COVID. Next slide. Right. This is the framework for diffusion of innovation, or how do you implement change in behavior? And so many of you have probably seen this before. It divides up anybody that needs to change into several buckets, a small group of innovators. And one of the features of that is if you're doing something for the first time, you're not always going to get it right the first time, so there's going to be more failures and therefore higher costs to do it. And then the next group is early adopters. These are early folks that have the benefit of what was learned by the original innovators so that they can in turn pick the best and get more value out of it. And what we've been talking about over the years is this is actually the sweet spot. If you want to stay ahead of the competition and everybody, this is where you want to be, because you don't have a lot of the try it and fail issues. You can work from what's there already, but you're already putting it in place and implementing things before the vast majority of others. So if there is a competitive advantage, you get the benefit of that. And so looking at the factors influencing adoption, you can think about this, what might get more people to do it and how quickly are they going to do it. If you have a better mousetrap, it's more likely to be implemented and implemented faster. Is it consistent with your own needs? How easy is it to understand? If you have a very complex process, it may be difficult to understand it and get people to pay attention to do it. And kind of be tested first. None of us want to implement something that may not work, so we want to look at evidence-based decision making. And does it provide tangible results? The concept of return on investment is coming into play in many decisions. Some of the cautions that came up, and there's a reference down the bottom there, is it works better for adoption of behaviors rather than cessation or prevention. So if we're trying to bring social care and integrate it and coordinate it with clinical care, that's adoption of behavior, so that might be easier than prevention or cessation. Things like smoking cessation and things like that may be a little bit more difficult. We need a clear understanding of the community context. And so that's some of what we wanted to try to provide here is, will this innovation work in my community? Are there special circumstances where it may work for you but not for me? And that we need to look for. And so that should be a criteria when you're looking at the innovations that have been put in place, is ask that question formally in looking at and evaluating the interventions. And then are there individual resources or social supports needed to adapt and adopt the change? And next slide. The big thing we find is that if you really want to compress the time frame, so if we want to get away from that 17 years to implement change into doing it now because we need it now, external drivers are the way to do that. And I've observed this for decades, that if you have a external driver, it could be a law that says you have to do it, or a regulation that says you have to do it, or in this case, COVID that says we better do it in a very short time frame. That eliminates the, well, I know we probably have to get around to it, but not now. That goes away when you have that external force. Next slide. So here are some of the major efforts in learning resources, and with the links to them. Probably most of you are aware of some of these. If not, here's some options to look at. So these are resources that you can look to see what have people done already over the last few years and essentially make judgments on might it work here. So Siren is a project out of UCSF, and they're really supporting the whole concept of screening for social needs and referral management. And they have resources on their website of lists of different vendors and different assessment tools and so on, with some evaluation of them. So if you haven't already picked your own, here's a place to go to see what might be available, what to look at. And out of that grew the Gravity Project. So Siren said, here's your alternatives, go look at them and choose what's right for you. What Gravity is doing is trying to say, what are the best practices? Can we create and maintain consensus and build core data and standards so that we can use the results of the information collected through the screening and referral processes to help set policy. And they're focusing initially on food and housing insecurity and transportation access, because those were the most common needs that were coming up, and they had some hope at doing that. And the link there will bring you up to date and have linked to all the discussions to date and where they stand currently. Aligning Systems for Health is looking at cross-sector alignment, and particularly healthcare, public health, and social services. Add the three together, and they have many reports out on their website that talk about doing that and the need to do that. And that really sounds like response to COVID-19. We really need to engage healthcare, bring public health more to the fore, and integrate social services with it. So there's many reports out there. CMS's accountable health communities, there are 30 pilots around the country looking at screening, referral, navigation, and so on. One of the interesting findings out of doing that is there was a lot of trepidation on the part of the healthcare providers that the clients would be uncomfortable talking about their social needs. And one of the first things that they found is the clients didn't have a problem talking about what their needs were. It was a problem for the providers. And so get over it and ask about and address and refer to get the social needs met makes sense to do. CDC has a program they call 618. It has 6 common conditions with 18 evidence-based interventions to address them. It's sort of a laundry list of what can you do to implement quickly some of the major focus areas on chronic diseases. Center for Healthcare Strategies, they have a whole series of resources out there, reports, pilot cases, and so on, as does Health Leads and Health Begins. There's various toolkits available. There's links to webinars. And one of the things we point to there as a specific example is last year, the Commonwealth Fund put together a new tool to actually calculate the return on investment for meeting social determinants of health. And so a detailed webinar is available, the recording there. If you just go on the Health Begin site, click on the Webinars, Resources and Webinars tab, and scroll down to July 31st. That's a good webinar to really look at how do you calculate ROI to convince the powers that be that this is a good idea and it's worth it as well. And all in and dash are Robert Wood Johnson projects. They have projects and resources, and Matt will be covering a specific example of that. Next slide. Some of the referral platforms that are available on Siren to see their characteristics. Aunt Bertha you may have heard of, Now POW, 1 Degree, Unite Us, and so on. There are some of the platforms out there to manage referrals, as well as pointing out on the top line, we have a series of ICD-10 codes. They're in the Z code chapter to collect data about social determinants of health, and there's quite a few that are in there now, and more will become live in October of this year. So that's going to provide us an opportunity to collect through the billing system the codes that address what some of the social needs are, so that we can analyze the outcomes from both a clinical and social need perspective going forward. Next slide. And here are some new things. We have some of the areas that have come up just in the last couple months. The NAM APHA COVID-19 Conversations. There's a series of 7 webinars that were put together jointly by the National Academies and APHA. And the first set of them actually were a distillation of the evidence briefing papers that were sent to the White House to help focus what do we do about COVID-19. And there's 7 of them out there, and particularly 1, 3, and 5 were very informative from my view. One of the things for looking at social determinants is also looking at multiple sectors. What can we learn from areas outside of health delivery? And from a technology perspective, we already talked about telemedicine. I remember this being around for the last 20 years, literally. And we're finally seeing an expansion into the mainstream. And from what we've seen so far, everybody likes it because it saves a lot of time, and we don't have to think about going to a crowded waiting room full of sick people. That was an issue even before COVID-19. So I think that one's here to stay, but that brings up something that the closing of schools highlighted, and that's the digital divide and the broadband gaps. So once schools closed around the country and everybody went into virtual learning, all of a sudden, oh, we have 50,000 students that don't have access to a computer and broadband, so they're not in school anymore. And that's both in inner city areas and in rural areas as well. So there have been a number of efforts to fill the gaps on a local basis, including having school buses with mobile hotspots go out into the community and park so that the children that live around there can get their broadband access. And there's a number of coalitions in local areas pulling together to actually build out the broadband access into the community and subsidize the connection. So that's something we can learn from schools. Density's been the real big issue on looking at some of the hotspots, and particularly with nursing home and assisted living catching the headlines quite a bit, and individual states getting 20, 30, 60% of the deaths in the long-term care, senior care, high-density communities. However, there may be many that are missing if you just focus on the nursing homes and assisted living facilities. So there's a project that looked at identifying buildings with at least 50 elderly at-risk residents in Detroit. And they found that they had 214 buildings where that was the case. The way they found it is they pulled in the voter registration rolls, looked at people over 65, and looked for the same address. So when they clustered them together, the 38 that they had previously identified is only 18% of the total. So if we're looking at focusing efforts to try to get better prevention, here's a tool that we can get from data from voter registrations that we don't normally think of as healthcare data. Another example, manufacturing, basically looking at the concept of process flow and bottlenecks. And testing has been a major issue for quite a while now. And the concept of pooled testing has been around, and some researchers are starting to look at it. And there's a reference there to folks that do it. And this looking at testing ranges at once and then focusing in from there to get the details is similar to the approach that was used to finish the Human Genome Project much faster than expected. A little caution, that will work now when we have small numbers, small percentages of positive COVID patients in the population. And another issue becomes when you're pooling samples, you're basically saying, let's test the whole group at once. If they come out clean, then we can forget testing anymore. They're clean. So you have to make sure that the test you're using is sensitive enough to be able to say that. I've even heard someone suggesting that workplaces can use this, and they used an example of throwing 200 samples in together to see if that works. And that will work now when you only have a few positive cases in the community, but may be a lot less efficient as the herd immunity increases and the number of people exposed to COVID increases over time. I forgot to mention up above on looking at the high-risk buildings, if you go to the Health Affairs article there, the researchers that put that together also offered to run the data for others. So if you think that might be a good idea for your community, you may have a resource to actually have them run it. And then geographic differences in COVID mortality, equity, we're seeing more and more of that. And one question that came to mind for me is, why is it that New York City does have a disproportionate death rate, but it's only 1.25 times the normal rate in the population, whereas Kansas and Wisconsin have 5+ times the mortality rate in the black population versus the percent of the population. Why the range? And it may be because there's more community health workers per working population in New York City versus Kansas and Wisconsin. It may be because New York City has a existing multi-year history of having housing and health work together at improving health for the overall community. They've been doing that for 10+ years, and so that may be part of it. So those are some ideas on where you might look to improve your area. And move on to the next slide. And Matt, you're up.
Great. Can you hear me?
Yep.
Great. So thanks, John and Jonathan, and the folks at NQF for allowing us to have this opportunity to speak. So thanks very much for that overview, John. I think there's a lot of things, and I have a few questions to ask, but I would like to get through the slides first, and then maybe if we have time for Q&A at the end. But I wanted to talk about this Chicago project that we did that's part of Data Across Sectors for Health, or DASH. So some people on the phone maybe have heard of the DASH initiative before, which is through All In, Data for Community Health, but maybe some have not heard of it. So I definitely recommend taking a look. And again, you should get the slide deck after this presentation. This is one of many different sets of resources that are available right now for people to tap into, and a lot of work going on across the country. Maybe not as coordinated as we would all like, but certainly lots of things that people can take a look at and build upon. What I'm going to be talking about is a specific Chicago example from when I was with the health department, and then I'll get through these slides and hopefully we'll have 10, 15 minutes for Q&A. But I think that the project I'm going to present is on lead poisoning, but the themes are completely pertinent today when we're talking about coronavirus and COVID-19 response plans and everything, especially as it relates to social determinants of health. And if you think about the issues we're facing right now, and John talked about some of the health disparities we've been observing, some of these have been known for a very long time, and they're certainly being highlighted and reinforced through what we're seeing with the coronavirus response and how it's taking shape. But certainly plenty that can be done in the short term to help improve and at least diminish slightly some of those disparities. And where I'm going with that in terms of social determinants of health, as we shift from a largely healthcare-driven response towards more of the public health response with contact tracing and ensuring the testing is made available and the like, we'll see that we'll have more folks that will need isolation and quarantine. That's going to be very much a reality. And as people are in those situations, their social needs certainly come to the forefront. So thinking about this now is absolutely welcome. And it's definitely time to move these things forward. And hopefully there's some things you can take from this conversation today and take these back and try to move with them. So this project, though, was, again, it was funded through the Robert Wood Johnson Foundation and was part of a multi-sector initiative with lots of groups from across the country, and we were a member of that project through the Chicago Health Department. So next slide, Jonathan. This, again, was the DASH initiative that's part of the broader initiative called All In, which is, again, this large grouping of organizations that are trying to bring together health departments and lots of other different sectors that are involved in meeting the needs of individuals in their community and helping find ways to bridge those gaps that are naturally there to improve multi-sector data sharing and the like to improve health. And this will hopefully be a little bit more clear in the next slide. Some of the different groups that were involved. So if you look in the upper left-hand corner, this is the DASH project, which again, Chicago was one of the DASH grantees through this Robert Wood Johnson initiative. But as you can see, there's a lot of different groups that are doing things that are all part of All In. And again, the slides have the web links to them, but if you want to take these down, so All In is available at allindata.org, and DASH is available at dashconnect.org. Again, that's All In is at allindata.org. DASH is available at dashconnect.org. And again, these are it's a fantastic quilt of organizations that are doing a lot of work here, and plenty to pay attention to and tap into in your own communities. And it's just a matter of, I think, taking a look at what they're doing. And this is just a couple of the many things that are going on that, again, John went over in his part of the presentation. So next slide. So again, this was all in the context of social determinants of health and how we got brought in at Chicago. And of course, these are certainly quite relevant at this time with coronavirus and what we're trying to do, and a few examples listed here. So the way that we were working on this in Chicago at the time was really around lead poisoning, because we knew that there were issues to do with, on the environmental side, that had long-standing issues. Chicago has very old housing stock, but these issues persist today across the country, and I think, again, they're just as relevant today, especially with coronavirus, as we were trying to tackle them with our lead prevention program. Next slide. So this initiative, again, was through the Data Across Sectors for Health group. And what happened was our health department partnered with these three main entities here: University of Chicago, Alliance Chicago, and our central IT team. And the project was all about preventing lead poisoning in children. And just to talk about these main entities, so we'd also tried partnering with the Chicago Public Schools and also Department of Buildings, knowing that we would need a very tight sharing of data in order to really help move the needle in this area. And for a few reasons, we weren't able to move parts of the project forward with the school system and also with buildings. But this part that I'm showing right here was a very specific piece of this broader initiative. So we had started doing this work in 2014, and by the time we got involved in the DASH initiative in 2016, we had already made considerable progress, and this really did just push it very much forward. But these partners here worked on this very specific component that I'm going to talk a little bit more deeply about, but also want to share that context of working with the public school system and also with the Department of Buildings to really have a multi-target, a multi-sectoral approach to responding to lead poisoning. And that's just as true today. You've heard the phrase maybe an all-government approach to coronavirus, and that I know that Chicago Health Department today is working very closely with sister departments and agencies along with the healthcare sector in really pushing things forward in a very big way. And if we have time to talk about that at the very end, I'll go into that a little bit further. But this is about preventing lead poisoning. So next slide. Just briefly, we all know that lead poisoning is bad. In Chicago, there are about 3,000 new cases of lead poisoning every year, and I think those numbers are getting a little bit down now, but at the time, about 3,000 new cases every year. It's 100% preventable, and so we knew that we needed to do something to improve our process. Next slide. So the initial process, and this is true in health departments across the country, was from a very reactive posture, and we're trying to make it a little bit more proactive. And as you can see from a reactive side, the child would get poisoned, the hazard would be identified from that poisoning, and then we remove the hazard. We wanted to get a little bit more predictive, a little more proactive, and that's illustrated here. And I think this also applies to coronavirus, and I think this will be kind of made a little bit more clear in the next slide. So just to dwell on this for a second, again, talking about lead poisoning, but how this also applies to an infectious disease public health emergency like we're dealing with right now. So if we had taken just a take them as they come kind of approach to lead poisoning, and similar if you do the same thing for coronavirus, you can see how there's opportunities for efficiency and really being a little bit more tighter with your resources. So the first map here shows with no prediction, no data-driven approach, then, how would you do this? It's almost 200,000 buildings in the city of Chicago alone. This would take almost a century to do, three-quarters of a century, and cost almost $100 million. But then with the current model of focusing just on 43,000 buildings or so, you get significant improvements. And then based upon the predictive models that we were building in concert with the University of Chicago, really fine-tuning and getting your hotspots really targeted. And I bring this up because I think it's important to highlight how a targeted approach is so critical and so important in, I would say, quiet times, like when you're dealing with lead poisoning, but also during emergencies, such as coronavirus. And I know that there's a lot of work these days on building dashboards and improving your business intelligence, and I think that's fantastic. All of that will come together in really improving the availability of information and what's going on with the situational awareness for where coronavirus might be located in your communities. This is essential work, and your health department staff are likely hard at work doing this. Partnering with them will be essential to getting that information shared in a way that makes sense, that's also accounting for privacy and security, but also improving the precision and the focused efforts that we need to have at this time. So next slide. This was, again, the team and the groups that were putting things together. The health department was kind of leading the effort. Alliance of Chicago worked with us and at the health department and with the University of Chicago. And Alliance of Chicago is in the city of Chicago is a series of federally qualified health centers, FQHCs, and they provide services through dozens of satellite clinics throughout Chicago. And the goal was to try to get our prevention model that I was just referring to into the hands of pediatricians so that they could have better conversations with their patients over what kind of risk level they might have. And so if we can go ahead and take a look at the next slide, the model was based upon a bunch of different inputs and the like, and based upon this information, the goal was to try to find a way to improve our information at the health department level so that we were going to have more targeted inspections and a better allocation of our limited resources, but also helping improve that integration, that data sharing across sectors with healthcare and other related entities. And I'll show you how. So the next slide illustrates just a little bit of what our kind of end products were. You can see in this upper right-hand graph or picture this prioritization effort that came about through our focused work and our modeling. And based upon this information, we were able to way more finely fine-tune which areas we're going to target with our inspections and the like. And it was manifested within this sort of daily dashboard. And this dashboard was used to show us on any given day what kind of facilities or where these buildings were that we needed to inspect, and just try to make it a little bit more proactive rather than so reactive. For Alliance of Chicago, this information was built right into their electronic health record system, or their EHR. And the goal was to provide that provider, that doctor or nurse, with better information about the risk factors for that patient, that mother and that child, so they would have a little bit more information to have at their fingertips for that encounter. And we worked with our central IT team to build what's called an API, Application Programming Interface, to share that data with the Alliance of Chicago in real time, so that as they were having that doctor's visit, the information would pop up within their electronic health record system, and they would have the information at their fingertips so they could talk to that patient about the risk that they would maybe have. And I just wanted to also show that little map in the corner. It was interesting when we got feedback from the doctors. A very interesting story. They were interested in the clinical decision support that was going to be from or through the electronic health record system, but they were also interested in just higher level data, knowing where the hot pockets were for lead poisoning in the city. And as you can see from this map, it kind of illustrates where those pockets are. So it's also important, I think, to engage with your customers and your stakeholders as you go through the process to see what's valuable for them. Next slide. So I think this is my last slide, and then we have just the summary and next steps, and then maybe a little bit of room for Q&A. But I just wanted to share this and say that this was a fantastic project that was already moving forward before we got involved with the Data Across Sectors for Health initiative through Robert Wood Johnson Foundation, but this really gave it a kick forward. So I think that even as we just pivoting to coronavirus then, this is absolutely the time to be engaging with these multi-sectoral initiatives like this, because you'll be able to, I think, from my perspective at least, build upon what's going on in these communities and learn from others that are have been working on these things for years. And I think it helps really do reinforce the good work that's going on, and also kind of hone in on things that you can do that I think are shovel ready and get things going in your communities. And that's the last.
Great. Well, that gives us a few minutes for questions, and I want to remind everybody that you can pose your questions in the chat box, or we can take questions directly on the phone lines. If you'd like to ask a question and you're on the phone right now, you can hit *7 on your phone to unmute your line and ask your question. And we'll give a few seconds here for people to do that.
I have a question for John. Go ahead.
Sure, yeah, go for it.
Okay, yeah, just a quick one for John. So, John, I appreciated that the recognition that telehealth has been something that's kind of been slowly moving forward for decades, but really advanced forward just in the past couple months as we looked at coronavirus. What are some other things that you were thinking that groups can start thinking about right now in the midst of coronavirus that kind of fit along these lines? What things would be maybe the first step you would take if you were new to this area and wanted to start, say, today or tomorrow?
Well, I think, as you pointed out, a lot of the issues that have generated health inequities and disparities previously are still there. The causes for the equity disparities have been there. They're still there for COVID. They will be there for the next challenge we have unless we fix them. So I think whether you're looking at COVID, whether you're looking at preparing for value-based payment where health is the principal focus that we're looking at, we need to start somewhere. So some of the areas that appear to be ready for a little bit more address is things like the nutritional and housing insecurities. And so we've seen, I was on a disparities call this morning from our local area, and they were talking about the people in need of food to be able to eat are not necessarily the ones that are being served by some of the food drives that are coming out under COVID, but we can identify where those food deserts are. There's been plenty of time to do so, and now may be the time to do it. The housing situation, the big driver from COVID perspective is the density of the housing. So people are not living alone. They have a lot of people, and it could be multi-generational. And so you do have children going back to school could become carriers for COVID to cause issues for their grandparents that are living there. And so finding where the at-risk seniors are, particularly if they're approaching half of the mortality nationally, makes a lot of sense. I think you had mentioned you'd reached out to some of your Chicago colleagues.
Yes.
And they were now looking at using some of the same issues to address COVID.
Yeah, and I'll speak to that just for a second, and it relates to the question that I saw that popped up from Sven Berg about the projects being data intensive and getting access. So someone once said, and this is not me in my quote, but data sharing moves at the speed of trust, which is, I think that's certainly true. It takes a long time to build up those relationships. And we are certainly in an emergency. This is not the best time to be building those relationships. We do have to start somewhere. And I think there's plenty of breaking the glass scenarios that are going on. And one thing I will share And what I mean by that is since it's an emergency, people know they need to share data, so a lot of things are happening in a short amount of time. In the city of Chicago, the health commissioner wrote an executive order or a directive essentially saying that healthcare systems would share data with the health department as a neutral convener to help inform the understanding of coronavirus spread and testing and the like that's going on. And I know that Rush University Hospital in Chicago donated an instance of their electronic health record system called Epic. And the facilities, many facilities, I think it was over 9 healthcare systems, started sharing data nearly immediately as it related to healthcare. So I think there's ways that you can get past this. Again, it does move the speed of trust, and it takes time to build that trust. But certainly these are times when if we engage with the health department leadership and healthcare leadership in any area, we can build that case to show where the access to data can make a big difference. And I will share one thing is that many health departments are sharing an unprecedented amount of data on their open data portals. So there is a fair amount of information becoming readily available online. It won't be patient level because of HIPAA privacy needs and the like. But those partnerships are key, and I think that's probably one of the best ways to engage is starting with those groups.
Good. And we're all hopeful that we get more data access. That was one of the frustrations we had on the action team for SDOH data is just not out there. But I think we're seeing more and more granularity of the data over time. We can now get pretty decent data down to the county level now, and it's widely available. Even the county health rankings information is also available in several platforms where you can pick your group and go look at whichever of the indicators you want. So we're moving in the right direction. We have a ways to go.
Yeah.
Well, John and Matt, we are at the top of the hour, and I want to thank you both so much once again for sharing your insights with the community. Just a tremendous amount of good resources here in this presentation. I'd also like to thank everybody who joined us on the phone today. We hope that the information that was shared will be informative for you as you try to up your game in these areas. We know that many of you are on the front lines of the response, and we're grateful for your leadership and action with regard to COVID-19. Please be on the lookout for a brief survey about today's program. If you could take just 60 seconds to give us your feedback, we would appreciate it. And I encourage everyone to tap into our amazing community of healthcare quality leaders like John and Matt. We have an active conversation underway on our online member portal, Member Connect, and both the slides and the recording of this program will be posted there shortly, so keep an eye peeled for that. So that concludes our program for today. On behalf of everyone at NQF, we wish you all continued good health amidst the COVID-19 pandemic.
Thank you. Thanks, John, Jonathan.
Yep, thanks. And look at those other NQF webinars that are out there. They're great. I've been on several.